Not mine. Kunal has everything. Audio? 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 Okay? Good afternoon, everybody. Small but select audience. I'd request the people at the back to please come forward if they would. So we have some interaction and discussion during this retinal session. My name is Somdat Prasad. I'm sure a lot of you know me already. And I'm going to talk about the new frontiers in the management of retinal diseases. Now, retinal diseases are a huge area, so we can't cover everything. So I'm focused on forget that, that's the financial disclosure side. I'm going to focus on neovascular AMD and what we do now, what we are doing now, and what we hopefully expect to come out in the next few years, in the next sort of 18 months. So that is my brief for today, because the topic itself is too wide-ranging to try and cover in one talk. I'd like to thank AIOC for giving me the opportunity to present here. Well, if you look back at AMD, this is old knowledge. We all know that about 90% of visual loss, severe visual loss, is because of wet AMD, neovascular AMD, and dry AMD, although it contributes a larger number of cases, does not have that much of a severity of visual loss, so it doesn't impact the patient that much. Until maybe the 80s or even 2000s, we actually told patients we couldn't do very much about this. Now, if you think about it, 2000 is not that far back. It's less than 20 years back. Yeah, and we used to tell patients, sorry, आपका हो गया, अब तो कुछ नहीं कर सकते हैं, आप जाइए, आपका पीछे गया. Because there was the evidence from photodynamic therapy which was being used with limited results. And the outcome from photodynamic therapy really was that people were saying, okay, instead of being totally blind, you'll be partially blind. Not more than that. And then before that, there was MPS laser. If people who are old enough to remember will remember that. It was like, I'll make you blind now by shooting you with laser so that in 3 years' time, you'll have better vision than you would have had if I hadn't treated you. So those treatments were not intellectually or morally appealing to us. Till in around the mid-2000s, 2006, Lucentis became licensed. Ranibizumab, I'm asked not to use trade names, but ranibizumab became licensed as the treatment for wet AMD, which suddenly made a whole change. It changed the paradigm from, all the disease progressions, somehow don't put them on the blind register, to, actually I can make some of them better. Only 40% better, not everybody better. 90% stable, 40% better. But I can make some of you better. So that was a whole paradigm shift, and obviously there was a shift also to using frequent intravitreal injections, which was a strange thing to us then. Till then we had only used intravitreal injections for treatment of endophthalmitis and stuff like that. So we were not used to using intravitreal injections as a routine therapy all the time, but with time obviously things have moved on, and anti-VEGFs have become established as the gold standard of treatment for neovascular AMD and other diseases like DME, macular edema due to RVO, whatever. But there are still some unmet needs, and we'll come to that and how we are hoping to maybe address that in the future. However, if you look at the figures, and these are observational studies, so this is real life data. This is not Marina, Anchor, because those things, in a tightly controlled scientific study, you will get results which are not reproducible in real life. In real life, you can't do that. But these are data from Sweden, from Israel, from the United Kingdom, and from America. The American data is not so robust. It's from theoretical modeling. But a lot of people, about 50% on an average, give or take, yeah, on an average 50% of patients managed to have, since we started on anti-VEGF therapy, managed to have retained the vision or get better vision. I'm dumping the American data one now because theoretical modeling is maybe yes, maybe no, we don't know. But the Swedish and the British data are all solid, and the British data actually I was part of collecting it, so I know how it was collected, and it's solid. And the message we got from that, which a lot of us are still reluctant to do, and I still have colleagues who say, oh, बहुत ज़्यादा injection दे दिया है, that is not true. You know, the message we got from that is treat early, treat sufficiently, and sustain treatment. There are long-term follow-up studies, I'll come to that, 7-up, etc., where you know, the initial gains were sustained and then they were lost because the patient started having less injections or less frequent visits. So actually you have to tell these patients from day one. You know, patient walks into my clinic, I see them, I see their OCT. Sometimes I do a DFA, sometimes I don't. We can discuss that if you want to. And I tell them, look, in year 1 you're going to need 6 to 7 injections. I don't tell them you're going to need 3 injections. I tell them in the year 1 you're going to need 6 to 7 injections minimum. And then we start on your treatment. Because then that patient is committed to that course of treatment. If I start off saying I'm going to give you 3 and then I say no, you now need a 4th and a 5th and a 6th, that patient stops believing me. So it's better off from day 1, from kickoff, to tell them this is what the study says, this is what the average patient needs, and this is what you are going to need. So you be prepared mentally, financially, everything, that you are going to have all these injections. You want to come and see me every month. We'll come to treat and extend later, but generally I still follow a PRN regime. You will come to see me every month, you will have an OCT almost every month, and you will have 6 or 7 injections in year 1. In year 2 it might go down to 4 or 5 injections. In year 3 it might go down to 2 or 3 injections. But you will still be needing treatment. And if you want to retain your vision, you have to sign up for that whole thing. It's not a pehla wala laga dijiye fir dekhte hain. That doesn't work. You know, that is wasting the patient's money and your time. You know, no point doing that. So that is one point. So what are the challenges associated with an AMD? Obviously, you know, this whole business, I've just told you, I want to see the patient every month, I want to OCT them every month. You know, that is a big load on the patient. And remembering that most of our patients are paying out of pocket for all this. You know, there's no government health system which covers this. There are some government health systems which supposedly cover this, but you know, they can't keep up with the time scales. So it doesn't work. And the incidence of an AMD related blindness has been reduced, but maybe not to the extent it could have been reduced because of the logistic issues, the financial issues, and other issues involved. So what do we still want to do? We want to reduce the number of visits. We want something which acts for longer, so we don't have to give it every month, or at least monitor every month. We can say after 3 months come or 6 months come, then that problem is solved. And that reduces the the burden on the patient and on the doctor itself, you know, because also all of us like to have a busy private practice, but you know, sometimes it becomes too busy. So it does reduce the burden on you if you have a scientific regime saying, okay, I'll only see you in 3 months, I don't need to see you before that, and makes the patient happy. As a general rule, the patients who receive more injections, and it's not on this slide, but from Luminous data. Luminous was a post-marketing surveillance study which the company who makes this drug did. Most of the patients who did well actually had 4+ injections. So again, I come back to the point saying that if you are going to give 1, 2, 3 injections, say goodbye, then you are not doing your patient any favor. You have to start from day 1 saying you have to get at least 6 or 7 injections. Because most of the patients, like in this slide, it says, you know, 7, 8 injections is the optimum for them to get the best outcome for vision. And that is a difficult thing to say, because the moment you say that, people think, okay, whatever, 30,000 into 7, 2,10,000 का तो ये बात अभी first time मैं आया हूँ, ये तो सीधा 2,10,000 बात बोल दी है हमको. But that is the cost of retaining your vision. Unfortunately, there's no other option. And we can talk about options if somebody wants to do that later. But let's just look at some of the study data. I'm not going to go into great detail with study data. CanTreat from Canada, they compared monthly injections versus treat and extend, because monthly injections for neovascular AMD have been the gold standard. The best outcome you can get at the cost maybe of getting more geographical atrophy is giving them monthly injections. Now that is obviously a bit cumbersome and expensive. Treat and extend is that you do the first 3 and then you extend the period as long as the stability goes. When they fall back, then you go back and then you start extending again. I'm sure you're all familiar with these terms, so I don't need to go into any great detail. But the maximum allowed interval is 12 weeks. So in 3 months, you will give 1 injection anyway, whether there's activity or not. Unlike PRN, where you will say, okay, no activity, no injection. So there are variations in how you treat patients, and that is entirely up to you, and you can take it as you want it. Treat and extend works very well in systems which are very well managed. Unfortunately, in our country, systems are not that well managed. So for me, I still stick to PRN, but that's a personal choice. We'll come to that. And there are comparable best corrected visual acuity gains with fewer injections in treat and extend than from a monthly regime. And so if you're giving monthly regimes, you'll give maybe 12 injections in the first year because you're giving one injection every month. But with treat and extend, you'll probably give 9 or 9.5, and you get the same outcome. Similarly, over 2 years, you would give 24 injections versus 18 injections, and you would get the same outcome. So it does reduce the number of injections. So in that way, it is a very logical method, which if you can keep that routine, the patient can keep that routine. Because our patients suddenly say, no, I'm going to Puri tomorrow, I can't come for 1 month, and then I'll come back and then I'll see you. So sometimes it doesn't quite work, real life doesn't work like the studies tell you. But if you can keep that regime, then treat and extend is a very, very good idea. Now I'll just move on to the next bit of my talk, which is the rival data. Rival is a comparison of ranibizumab versus aflibercept. Without going to great detail, this is the first head-to-head trial of RZB versus AFB using a treat and extend protocol. There have been other trials, but they were using other protocols. And generally, it has evolved from the previous studies, Anchor Marina, Horizon 7-Up, you all know that. There's nothing new to be said about that. Then it was thought that let us just compare the two drugs using what is now the current sort of standard of care is treat and extend, if you can maintain that system. And again, from these Australian studies at 7 years, it seemed that atrophy progression was associated with vision loss over time. So there is this debate going on, and this debate started from the CAT trials. The initial trials which told us, not the initial, the NEI initial trials, the industry independent initial trials which told us that these drugs work, is that also they create geographic atrophy. And there is then a question in our mind, are we using something too strong, which will give us more geographic atrophy, or rather we want to use something in between. So do you want to use a nuclear weapon or a thermonuclear weapon? It's up to you. You have both options in your hands. And there was some suggestion that maybe using aflibercept gives you more geographic atrophy than ranibizumab does. Obviously, that was later not shown out to be the case. If we look at the results of the FRB trial, that's an Australian trial, geographic atrophy was about 40% and various complications as listed there are not great. Geographic atrophy and subretinal fibrosis. Subretinal fibrosis is probably the big one because that is the one which drops vision more. But this is over 7 years follow-up. Now when you put these slides up, it looks very nice and we all think, oh, 7 साल में तो जाएगा ही क्या करना है. But remember, this patient is 70 years old already. If I can keep them seeing for 5 years, then 7 साल में जाएगा तो जाने दो. At least they've had that 5 years of quality of life. So you have to interpret these slides not just scientifically, but how it is affecting your personal patient. And for personal patients, okay, if I can keep them reading for 5 years, they can read their thing, they can watch the telly. Maybe in year 7 they lose that. That's fine. Well, that's not fine, but I've given them another 5 years of workable life, which is what you have to keep in mind every time we show all these nice graphs and slides which tell you various things. And like I said, it's been from the CAT days, it has been suggested that increasing the number of intravitreal injections, which is why people wanted to move from monthly injections to PRN to treat and extend. So we reduce the number of injections, maybe we reduce the amount of geographic atrophy, which, like I showed in the previous slide, is about 39–40%. So we get less geographic atrophy with the same therapeutic effect, which is a good idea if we can do it. The rival study was actually designed to compare, like I said, aflibercept with ranibizumab in a treat and extend regime. Ranibizumab 0.5 milligram is standard dose, aflibercept 2 milligrams standard dose. Screening to baseline, 3 loading injections, and then extending according to the regimen, which we'll come to. All the patients who were randomized, roughly equal numbers, properly done trial, no issues about that. Number of subjects who completed treatment were about 80% odd in both the groups, so that's good. No great fallout rate, and a small number who discontinued early. Baseline characteristics were generally balanced between the two groups, so you couldn't really say that there's a bias in selection. Whether you look at ethnicity, whether you look at best correcting visual acuity at presentation, gender, age, whatever, they were more or less the same. Very briefly in results, the number of injections was no different. So actually you're not, the whole promise of AFB when it came out was that we would need less number of injections. We were all very happy. I don't need to see my patients every month. I can see them every 2 months. I have to give them less number of injections. Isn't this a great thing? But it hasn't worked out in clinical life. In clinical life, they need the same number of injections, whether you're using RZB or AFB. And that was slightly evident even from the first trials they presented, because there was a sawtoothing of the data. I don't have the slide here, but you've probably all seen it. There was a sawtoothing of the data. Every month when you're not injected, the central subfield thickness went up, and then when they were injected, it went down. So there was some loss in that month when you didn't inject, but obviously the trial design in the initial InView and Vista was that you would inject every 2 months, so protocol dedicated that you didn't. But actually they lost something in between, then tried to recover it, then lost something in between, then tried to recover it. So nowadays, if anybody shows me any slides, I say, magnify it and let me look at the finer configuration before I believe what you're trying to tell me. And all of you should do that. There were no significant trends towards lower rate of macular atrophy with AFB, or more drying, or better visual acuity. So really, these two drugs were roughly the same. We're not talking costs here because that's not an issue. We can talk if we want. The only statistical significant difference was a suppression of VEGF with aflibercept. There's higher suppression with AFB systemically than there is, and even locally, if you measure it with AFB. But clinically, it does not seem to make a difference. Scientifically, that figure is there. The proportion of patients with macular atrophy at month 12 and month 24 again is very close. Watch those two lines. They are so close. There's hardly anything to split them. So again, I won't read too much into that. A little bit more maybe with RZB, but that is so close that it's not interesting. Efficacy, again, mean number of injections year 1, 9.7, 9.7, same. Mean number of injections year 2, 8.9, 8.3, not a real difference. Over 24 months, 17, 17. So with roughly the two drugs. What I'm trying to say is at least for NAMD and also from my experience in DME, these two drugs are the same. So it doesn't make a real difference which one you choose. Now you might want to switch, and that's a separate story. I think somebody else is going to talk about that later. Injection patterns, if you look at injection patterns over 2 months, the mean interval over 2 months, again, is very much the same. The number is 134, the mean interval is 6 weeks. So, there's really hardly anything you can toss a coin and choose whichever drug you want. It doesn't make a difference. The descriptive summary of that we've been through, so I'm not going to go through again. This is the change in best corrected visual acuity from baseline to month 24 in the rival data. There is a slight question mark about that little bit on your left, where in the first month, patients getting aflibercept did not get that improvement. You see that green line? It is flat and then rises. The orange one rises straight away, which is what we expect. Now, they've looked into this data, I'm told, by Mark Gillis, and who is the leading investigator of that. They have looked into it in great detail for why that has happened, but they have not been able to give you an answer. So we don't really know why that little blip in the graph is there. Why is it flat in the loading dose period and then it suddenly rises? But when it rises, it gets pretty close. So again, that's a difficult point of interpretation, but we'll set that aside. If you look at the changes in central subfield thickness, then again both drugs are very comparable. Very close lines, not very much different. AFB probably getting a little bit more drying than RZB, but not a lot in it. Safety results, I'm always very reluctant to speak about safety results, because safety results, none of these trials are designed to assess safety. If you want to do safety, you need a trial with 70,000 patients, not 200 patients. So anybody who talks about safety with 200 patients is talking through his hat. You can't do it. But anyway, whatever data there is there in this trial, in the rival trial, again showed that there was minimal anterior chamber inflammation in both the drugs, nothing great, 0, 1+ cells. Hardly anybody had 2+ or more than that cells. So 1 or 2 cells now and then, otherwise nothing. But take that with a pinch of salt, because these studies are not powered to study safety. Status of inflammation. Inflammation has become an issue now with two things. One is a biosimilar, which we have here, and one is an Allergan product, which is undergoing licensing with the CEDAR and the Sequoia trials, and there have been increased amounts of inflammation in those. Obviously, the drug going licensing is through a proper protocol, so we know those figures. The biosimilar figures are all hearsay, and we don't really know what is true and what is not true. So I won't comment on that anymore. But for these drugs, for aflibercept or for ranibizumab, the intraocular inflammation was very minimal, 0 or 1+ cells, and that is it, and that went away. So there was no difference in the number of injection. There were no significant trends towards macular atrophy being more with one drug. There's slightly more drying with aflibercept, but that wasn't statistically significant. The slightly better visual acuity with RZB, but again not statistically significant. The only statistically significant difference, I've shown you that already, suppression of VEGF with that. Just to finish that part of the talk, and then just briefly 2 more slides and then I'll finish, is that the conclusion really is that in a properly designed RCT, comparing RZB to aflibercept, using a treat and extend regime. Now you have to remember that, because that might make a difference, which we don't know. There was really no difference between these 2 drugs for NAMD. They did the same. Now you might say, oh, we have RAP and we have this and we have that. That is a separate thing that was not addressed in this study. Okay, so that is a separate story. We can go into that if you have time and if you want to talk about it. So let's just very briefly look at the future before we finish. What are the needs for effective therapy? The current treatment of neovascular AMD is very good. It has dramatically, like I said before, 2006 we used to tell them, oh, you have to go blind. There's nothing much I can do. I'll give you PDT. Just save 1 line or something, but not nothing. But we have dramatically reduced the incidence of blindness, and that has been proven in multiple countries through, where data is properly collected. However, the real world setting is there is still a problem, and I'm sure every retinal specialist in this room will agree with me. Can you get the patient in every month to see you? Can you do their OCT every month? Can you make the decision to give the injection? Once you made the decision to give the injection, will they take that injection? There are lots of ifs and buts in what I'm presenting you as the great good path, but that is always not possible. So there is a number of unmet medical needs which still exist. And what we want to do really in the future, if we can, is to reduce the number of injections and reduce the number of visits, so the patient doesn't have to come. So we need a longer acting drug. We need a more efficacious drug. So instead of saying 40% will get better, we need to be able to say maybe 70% will get better. We'll never get to 100%. That's not practical. And then we need to provide treatment options depending on what the patient has. So there's no monopoly. We have a multiple set of things and newer things coming, and we have to choose which one is right for whichever patient. Generally, the whole thing is aimed at improving the quality of life of that patient, which I've referred to before, because that will help them in their last few years, and we're just trying to guide them through their last few years as much as we can in a positive manner. We're not trying to cure this disease. This disease doesn't have a cure yet. But we're trying to guide them through in as much as we can. The next kid on the block probably is going to be brolucizumab, which has a fancy name RTH258. It is a smaller molecule. It binds more to the VEGF receptors. And I'm told that if all goes well, by end of 2019, which is this year, it should be released in the US and next year in the rest of the world. And the 2-year data from the thing, this is not even published yet, this is press release data. The 2-year data from Novartis, so we have to take their word for it. For brolucizumab looks very good. It reaffirms superiority versus aflibercept in reducing the number of retinal fluid in patients with NAMD. Remember, aflibercept had come on the market to give us the promise that we need lesser injections and we reduce fluid faster. But this one seems to do better. And again, 2-year Hawk and Harrier findings demonstrated that fewer patients had intraretinal fluid and subretinal fluid, which are the key markers for this. In 2 years' time. The full results will be available, I believe, very shortly. So yes, there are things being done. There are things on the block. And with that, I'll end my talking. And if anybody has questions, I'll take questions. Thank you.
With the due precautions, when we take with all the due precautions, vis-a-vis this, the bevacizumab, which we are using here, particularly because of the cost factor, in comparison to the Lucentis and the
So there is a legal problem with using bevacizumab. It's not an efficacy problem. Okay, the efficacy problem is maybe there a little bit in some studies. But in the Western countries, we always quote these studies saying that in the ASRS survey, 50% use bevacizumab, or in the Asia Pacific survey, so many people use bevacizumab, and everybody does. But there is a level between you as a practitioner and the company supplying it, which is the compounding pharmacy. So the compounding pharmacy draws this up, sends 2 for culture, keeps 20, then gives it to you. You open a single-use drug and you use it. You are covered. Unfortunately, in India, that is only possible in Rajendra Prasad Center and in the Arvind system, because they are not allowed to sell that outside. So all this fudge, and I hope there are no press here, all this fudge about due precaution is not due precaution. We are not following the right protocols. If you get what I mean. I used to use Avastin in England, and I was given a single-use syringe in a sealed packet, which I open and give it to the patient and go. But to that to the majority of Indian ophthalmologists is not available. So VRSI has thankfully come up with some guide which gives you some protection, saying if you do this, then it's okay. But actually that is not what is the scientific truth. The scientific truth is, if you want to use Avastin, please do, then change the law in the country, get RP Center compounding pharmacy to sell it to you. Or import it. I even looked at it from importing it from the Lions Eye Hospital in Perth, and they said, no, we can't guarantee that over that duration of flight, this thing will be stable. So I personally do not use any Avastin whatsoever, because I mentally I cannot satisfy myself that I'm meeting the clinical standards which I need to meet. And every time we say the Americans use 51%, the Americans are using a different Avastin from what we are using. We used Avastin when I was part of the IVAN trial. It was given to me in a glass sealed vial as a single dose thing. We drew that just as we draw out Accentrix or Lucentis or whatever you want to call it, or aflibercept, and we injected it. It was not given to me in a multi-dose vial where I was drawing out 40 injections. So there is a basic problem, and somehow we have to get together and get the law changed in this country to be able to use that without any blemishes on ourselves. Otherwise, there will always be that question that something has gone wrong because the doctor botched it up. Now that is my personal take on it. You might have a different take on it, and that's up to you to interpret.
As far as the efficacy is concerned,
yes,
the off-label treatment we are using, efficacy vis-a-vis the results, are there any great clinical results are different from the
There are slight differences. I could go into trials one by one, but there are slight differences, but not a huge difference. Not a huge difference. So you're absolutely right. If we can get the systems right, then that is a very affordable drug to use. Unfortunately, the current legal setting in our country does not allow us to get the systems right. Obviously.
And the reason for that is because, the reason for that is, let's go by the CAT trial only. The CAT trial also showed that the drying of the lesion on fluorescein angiography with Lucentis was better than with Avastin. So if you say, well, monthly Avastin and monthly Lucentis are comparable, but drying of the lesion is better with Lucentis. Now, if you see that the risk of a 3-line vision loss with PRN Lucentis and PRN Avastin, well, they did not do this analysis. This is something I just did personally. There is a trend because it's at P less than 0.08. But there is a trend of P less than 0.08. It takes 3 patients to shift it to 0.05. Let's be very clear. We have a trend towards better results with Lucentis. So overall, if you have to make a choice, if the patient can't afford it, you have a drug, Avastin works. But in a patient who can afford everything, right? My choice for the Indian population as the initial treatment would be Lucentis, except in patients with PCV, where the first choice is
different story. Yeah. I completely agree with that. You know, if they have PCV, RAP, then we go to
how soon can we expect brolucizumab?
I've just been told that 2019 end it should be coming out in the US and maybe 2020 in India. But we don't know. That is what I've been told. Okay, thank you. I'll like to invite, I think Dinesh is the next speaker. Dinesh, please, on the stage.
Good afternoon, ladies and gentlemen. ARMD is the scariest disease we have, but DME is the one which is most widespread and is on the way to becoming a capital, making India the capital of the diabetic capital of the world. Where do we stand with regards to diabetic maculopathy, which happens to be the most important cause of moderate vision loss in diabetes? So it's more common than proliferative diabetic retinopathy. Well, the new paradigm which we have is individualized. It's tailored to the individual's clinical status and requirements and optimizes the use of all the weapons that we have in our therapeutic armamentarium. Whenever you want to treat something well, whenever you want to fight a campaign well, it's important to assess your enemy. Anyone who's against me is my enemy at that time. So I consider diabetic maculopathy the enemy. Then assess what is your therapeutic armamentarium and formulate a strategy which keeps local perspectives in mind so that we can maximize the outcomes and minimize the costs. Now let's see the enemy here. The enemy is diabetic maculopathy, clinically significant macular edema. Remember, clinically significant macular edema may not involve the center of the macula. So as you can see over here, retinal thickening greater than 1 disc area, some part of which is within 1 disc diameter of the foveal center. This is the least severe form of CSME, and this you can have compatible with 6/6 vision. And this is retinal thickening involving the foveal center. And today you have all studies talking in terms of not CSME, but center involving diabetic macular edema. But remember, you can have center involving diabetic macular edema where the leak could be far away from the foveal center. It could be here. Now that changes the perspective, because anything which is far away from the foveal center is amenable to laser, and anything that is close to the fovea is not. So let's see, is this common or is this just hawa mein, talking about something in the air? The fact is, in the RESTORE study, DRCR-NET, 50% of patients had lesions which had a focal component. That means lesions amenable to laser, and you keep treating them with anti-VEGF, and it does only one thing: increases the number of anti-VEGFs needed. Now to see your patient, how do you still need fluorescein angiography because it can characterize the lesion very well. You know whether there is any ischemic maculopathy, focal leaks if they are there, where are those focal leaks, whether there is any associated neovascularization. All these things can be quickly done, and you can check the adequacy of your treatment after 3 to 6 months. OCT, of course, is the workhorse, so you use it to check macular thickness, traction, result of your treatment, early recurrence. Now, once you've characterized your disease, how should you manage? Now, this is not an eye standing out away from the body. This is an eye in the milieu of a human body, which has a complete change in its biochemical profile. Therefore, the first thing is change that internal milieu. Medical management is therefore extremely important. Control the dyslipidemia, control the HbA1c, so take care of the hypertension and start the nephropathy treatment if it's there. Now somebody will say, ये सब करने शुरू कर देंगे तो patient का treatment कब होगा? वो तो patient खराब हो जाएगा. Now let's show you one patient, one set of patients here. These have been given by a friend of mine, Dr. Vatsal Parekh in Mumbai. We were discussing about how anti-VEGF works and this and that. He said, so you do all that with anti-VEGF, I do it, I have patients who had all that with only medical treatment. So let's be clear, it is not just anti-VEGF agents. The most economical method is to treat his systemic milieu. It will take care of lots of other things also. And once you tell the patient he has an eye disease and needs systemic control, he is much more amenable to that treatment. For those who say it will cause a delay, I say there is no emergency. Now, you know, we don't listen to whatever an Indian says. What does the Westerner say? What is the evidence-based medicine? Now, this is evidence-based medicine. These two groups got monthly Lucentis for 1 year. These got nothing. After 1 year, all the three groups got PRN treatment. And in 3 years, what happened? You see all the three groups are more or less at the same point, except frequently for DME. The important thing is it's a temporary effect. You must understand that. Now let's come to actual patient. The patient is in front of me. He has a vision of 6/9. He's got a near vision of N6. And he's got an OCT which shows fluid. Would I like to treat him? No, I don't know. If it was my eye, I would definitely want no treatment, and any doctor who tells me that you need treatment, I would change the doctor. So the fact is, we know if these patients are started on treatment, and in protocol T they did that, these patients will need 8 to 9 injections in their first year. And what happens if we don't give those 8 to 9 injections? The fact is nothing happens. So where is the need for that injection? So the safest, and so what do? Continuous monitoring. We monitor these patients monthly. The first sign of deterioration, we will treat. So we don't take any negative effect on ourselves, but we don't waste the patient's money. Just to show you this patient, and this patient could have gone anywhere in the world. He was actually worth 1,000 crores. And I told him, look, you have this edema in both the eyes, but I'm not going to treat you. I think you can be managed, but I can send you to USA and I'm 100% sure you'll be started on treatment. Well, this is the picture 8 years later. No injections so far, 6 vision. He developed a cataract which was also operated. The point I'm trying to make is not everyone is going to behave like this, but many will. And why not give them the chance to stay away from injections as long as possible? However, remember, these are patients who are very active. So these are patients in the prime of their work, work life. So if the vision goes down to less than N8, not written in any book, not written in any journal, but practically speaking, if you have, okay. Okay, so he'll tell me which. So far, I haven't managed to read that. So, but the basic point here is, if your near vision is affected, you want treatment. If your distant vision is less than 6.9, or it's going down to 6.12, 6.18, you want treatment. So, if you have a decrease in near vision or a decrease in distant vision, both are indications for treatment. And this treatment is PRN from initiation till the patient's foveal contour normalizes and his vision improves to 6.9 or so, at least. Then you follow up after that. You don't stop looking at him. If he doesn't reach this endpoint, the monthly injections continue. Supposing on 2 continuous, now you've given the initial injections, now you're giving 2 more, and you find no change in the OCT findings, no change in vision, and the vision is still 6.12 or worse. This is an indication for changing to steroids, because it could work, and this, so your stability comes only after you've given a trial of steroids in these patients. So this is one of those lucky patients, but everyone is not so lucky. And after that, through the year, he has 4 weekly monitoring. Repeat the injections when either there's an improvement or if there's a deterioration, both are indications. But if it's not improving, I've already said steroids, and worsening is defined as more than 1 line deterioration or more than 10% change in OCT. Now with the best treatment that you're giving, now you want to know who's going to respond, who's not. So you have a therapeutic prognostic indicator. Now what is a therapeutic prognostic indicator? Patients who did not require an injection at month 3 or 4, these patients will not require too many injections. These are the patients who will do best, and these patients will need not only require less injections but show the best visual results. So 25% of the patients will come into this category. Unfortunately for us, there will also be 20% of the patients who will require monthly treatments. These are the non-responders. So now you know how they will respond, and the rest of the patients will come in between. So question is which? Now we're talking about bevacizumab, we're talking about aflibercept, we're talking about Lucentis. Well, 3 things come into mind. One is efficacy, second is cost effectiveness, and third is safety. All 3 are important to me. For efficacy, let's have a look at protocol T. Best, they've compared all 3 together, randomized control trial, highest level of evidence. And what it shows is that in patients with good vision, better than 612, all the 3 drugs seem to do equally well in terms of visual outcomes. In patients who have poorer vision, less than 20 by 50, 615 or so, aflibercept seems to stand out in the first year. And if you see this chart, you see the best vision group, not much difference. As the vision goes down, as the baseline vision goes down, the aflibercept seems to become better as compared to Lucentis and bevacizumab. Now, look carefully. Where is this difference coming? If you see, most of this difference comes in the first 12 weeks. So it seems that aflibercept breaks away from the other 2 drugs in the first 12 weeks itself. So a suggestion which for those who are retinal surgeons can try is, why not in those worse prognosis cases or worse visual acuity cases, if the patients can afford it, give them 3 injections of aflibercept and then shift over to Lucentis for maintenance. Cost of maintenance will become half, and chances are the cost of maintenance will become half and the results will not be affected. Of course, in this study also, in 2 years, it was shown that the trend towards the initial difference became less. But what I'm suggesting is something which can decrease the costs in the first year itself. So this is one aspect which we can think about. The other important thing, I think you asked about Avastin versus ranibizumab. What was seen in CAT is also seen in all other trials, including diabetes. Even in patients who had the best visual acuity groups, right? where visual outcome is not coming different. The drying of the lesion is better with aflibercept and with ranibizumab as compared to Avastin. So if I have to make a choice, if the patient can afford it, why would I subject him to persistent fluid when I can actually avoid it? So I hope that answers your question. Cost, you know, in this country, we not discuss that, but the more important thing is safety. As far as safety is concerned, the first issue is steroids versus anti-VEGF agents. I have actually no hesitations in saying I believe steroids are more effective than anti-VEGF agents. I say, then am I mad? If steroids are more, in diabetes. Yeah, I'm talking about diabetes. I think the topic is DME. So now, if steroids are more effective than anti-VEGF agents, then why have I been talking about anti-VEGF agents? The answer comes in this Cochrane review, which showed that the endophthalmitis risk is 1 in 1778 with steroids, as opposed to 1 in 5,283 with anti-VEGF agents. So it's a 6.92 times higher risk with steroids. And believe me, when it comes to safety versus efficacy, hands down, safety wins. For anyone who doesn't believe it, for your ARMD patients in subfoveal CNV, just do focal laser. All the lesion goes away, never comes back. And you've not even discussed it. Somnath has not even picked it up. Why? Because safety is more important, not efficacy. Therefore, I would prefer to start with anti-VEGF agents. Let me give you one rider of this Cochrane review. They have mixed triamcinolone with Ozurdex. So please don't get the wrong idea. We don't have a Cochrane review saying Ozurdex versus. So because the evidence at the moment is not clear on this, I would rather not take a chance with steroids as my first line treatment. They are my second line treatment. Now, as far as ocular safety is concerned, our only problem with bevacizumab has been in terms of cluster endophthalmitis, which is probably related to spurious vials, a peculiar problem for this country. As far as the biosimilars is concerned, we seem to be having some problems. We initially had problems that seem to have disappeared, but now we seem to be having some problems. So, because of that inconsistency, let's see the reliability and consistency of the results with the original product is what would probably give it an edge over any other alternatives. But there is one situation where I have no hesitation in saying leave everything else and use ranibizumab 0.3 milligram. That is patients with recent systemic events, a recent myocardial infarction or a recent stroke. In this situation, there is only one safe anti-VEGF agent. We don't have safety for aflibercept or for Avastin, only for this. So now, the last part of this is non-resolving macular edema, which is usually not because of true non-response, is usually because of inadequate response. And this was shown by the protocol U, where when the patients who were actually being categorized as refractory were given 3 injections monthly, half of them became okay. So before you label someone as refractory, please give him proper treatment. And then if it is truly speaking refractory, then you can consider treating that patient with steroids. So this is to show you how a patient could respond when nothing else is working. This just sums up everything. Good near and distant vision, conservative vision, management. Near or distant vision get affected. Preferred drug is ranibizumab. Vision less than 624, start with aflibercept and consider shift to ranibizumab. And if you don't get a response to 3 anti-VEGF agents, consider intravitreal dexamethasone. Ladies and gentlemen, with this individualized treatment of diabetic macular edema, keeping in mind your patient's specific problems, keeping in mind the greatest safety with efficacy, you can have the most effective approach to management of diabetic macular edema. Thank you very much.
Dinesh, I'm compelled to make these comments.
I think we'll remain friends after that, yeah. ETDRS told us defined CSME not on the basis of visual acuity. You'll remember that. Visual acuity is not a part of it. 12 years later, the same authors wrote a letter to the journal in the archives, which was published, which said if a patient has 6/9 or better vision, then please do not try treating him. You can follow him safely, which is that reference I was making, that this is actually, there is evidence to show that. It just appeared as a letter, so people didn't take notice of that. So that was one point. And the second point we are trying to make, that Cochrane review you were referring to about endophthalmitis, remember it is per injection. Now, per injection, we're talking 7 injections of an anti-VEGF versus 3 of a steroid, considering Ozurdex. Then that 6 times ratio falls down to a twice ratio maybe. And then they had mixed trials.
No, but this is number of injections.
No, this is per injection.
Yeah, per injection.
Yeah. So because you're using Ozurdex, if you are using Ozurdex,
okay, the number of injections will be
less. So actually that risk is not as dramatic as you're trying to.
Okay, so you mean it becomes 1 is to 2.5? Yeah, but it's still 1 is to 2.5.
It's still 1 is to 2.5, but then remember they had, as you said, they had mixed triamcinolone with Ozurdex.
Yeah,
so
but
we don't really
my
know.
point is, actually, I don't want to condemn Ozurdex based on that data, because they've not differentiated.
Exactly
so
what
I
I'm
was
trying
going
to say.
beyond that.
Exactly what I'm trying to say.
Yeah. Any other questions from the house? Okay, thank you very much.
Thank you. So good afternoon, everybody. And at the outset, I'd like to thank Novartis for this invite. So in the next few minutes, I'm going to take you through diurnal management of intraocular pressure in clinical practice. So glaucoma, an emerging peril. If you look at that, the number of glaucoma people is increasing, 12 million cases in India, and 90% of which is undiagnosed. So elevated intraocular pressure is currently the only known and modifiable risk factor for glaucoma. Higher diurnal and nocturnal fluctuations in intraocular pressure have been reported in glaucoma patients, and lowering intraocular pressure by 30% in patients with glaucoma reduces progression. The risk of progression is lowered by 10% with each 1 millimeter of mercury of IOP reduction. IOP peaks during the nocturnal period have been observed in healthy individuals as well, and patients with ocular hypertension or untreated glaucoma measured in the sitting or supine position. Asrani et al. Found that short-term daytime IOP fluctuations measured during home tonometry could actually be a risk factor for progression in those where we find the glaucoma is controlled. So post hoc analysis of patients in the AGIS study revealed that IOP fluctuation between visits over at least 3 years was an independent risk factor for visual field deterioration, and for each millimeter of mercury, the increase in fluctuation increases by 30%, as I just told you, and the long-term prospective study with a 10-year follow-up, it was found that IOP fluctuations in patients of ocular hypertension were the predictors of conversion to primary open-angle glaucoma. Other studies have also shown that relation between IOP fluctuation and glaucoma progression. So the factors which affect intraocular pressure, the general factors are diurnal variation, which I just told you about. IOP is higher in the morning versus the afternoon, and again higher at night than in the morning. Postures in the supine position is the highest compared to the sitting position, and exercises like isometric exercises can increase intraocular pressure. Systemic factors like Valsalva increases intraocular pressure, certain food and drinks increase intraocular pressure, and general anesthesia, ketamine and succinylcholine may increase the intraocular pressure. So if you look at the diurnal and nocturnal variations in intraocular pressure, These are the studies which were conducted as early as the 1898, where they did say that intraocular pressure had great fluctuations throughout the day and in different positions. So intraocular pressure fluctuations throughout the diurnal period, if you look at that, nocturnal supine intraocular pressure was higher than the diurnal IOP in patients with glaucoma and healthy adults. So you look at that graph out there, and those triangles that you see are the glaucoma patients, the colored triangles, and the circles that you see are the healthy controls. So if you look at this part, the pointer is not working. So if you look at basically the center at night, there you see both the healthy individuals as well as the glaucoma patients had higher pressure than they did during the daytime. So the need for diurnal intraocular pressure measurements. So you could see that a patient is stable, but then there is progression on your fields and OCT. So IOP peaks during the nocturnal period. Clinicians usually assess IOP and therapeutic efficacy of IOP lowering agents during office hours. Single IOP measurements in the sitting position during the normal office hours do not reflect the true range of the individual's IOP, and peak IOP or variations during the day could actually cause the progression. And 24-hour IOP monitoring studies have shown that higher peak pressures and wider fluctuations in IOP were observed outside the typical office hours. So the benefits of diurnal IOP measurements in patients is detection and risk progression. So aggressive IOP lowering therapies can be started, and analyzing a 24-hour IOP curve can actually reveal the higher peaks and the wider IOP fluctuations which occur outside office hours. And a study has been done and found that this led to immediate change in therapy in over 1/3 of patients when you know actually what is the time that the IOP is fluctuating or rising. So the benefits of diurnal IOP measurements in glaucoma patients: first, you have the individualized management where the response to IOP lowering medications varies from patient to patient and may reduce the rate of change in glaucoma and improve treatment outcomes. Then the improved adherence, you need to give chair time to your patient to explain that IOP is not a constant factor. It does vary with time and with position, and you need to adjust your doses likewise. And behavioral changes, certain occupations and patterns actually do increase IOP. So treatment options to lower intraocular pressure. Treatment is to lower intraocular pressure by 20 to 30% from the baseline values. So you have the medical therapy, you have laser trabeculoplasty, and you have trabeculectomy, the gold standard, followed by the glaucoma drainage devices. So what do guidelines recommend? First choice of monotherapy, always start with one drug, never with two drugs. The commonly used monotherapies are generally the prostaglandin analogs because they provide a 24-hour control. If it works, that's very well for the patient. You just need to put the patient on follow-up and see the patient at regular intervals. If it doesn't work, then you need to substitute that and finally add a second drug for achievement of target intraocular pressure, and then again the patient goes on the maintenance therapy. Again, if it does not improve with that, when you switch the monotherapy, then you need to consider, which monotherapy is effective, and then again go on to the second line. But always remember, never add a combination, give a combination drug or two drugs at a single point of time, because you do not know how much each drug is going to lower the pressure. So the efficacy of different regimes for primary open-angle glaucoma, a meta-analysis showed that prostaglandin analogs provide the best intraocular pressure lowering effect amongst all monotherapy regimes. So if you see the comparison of the PGAs in diurnal IOP control out there, you have travoprost, latanoprost, and bimatoprost, and they almost all have the equal efficacy. Bimatoprost and latanoprost show maximum loss in efficacy in between the 18 to 24-hour period dose, whereas travoprost did show an effect there. So quality use of fixed combinations. You have certain fixed combinations which you can use that makes it easier for the patient to install, and it's easier to keep it in one single bottle and use both the drops at the same time. They generally have the same efficacy if you're using 2 bottles in 2 different times. So fixed dose combination with timolol, if you have a look at it, timolol actually has low additivity to the prostaglandin analogs. However, the highest additivity it does have is to travoprost, if you see out there, that's 34.9% that is there, whereas the rest are much less. So this study was conducted to see the combination drugs which is the best. So brinzolamide and brimonidine, it's a pioneer study done, and we were one of the centers who conducted the study in India, and it was a double-masked, randomized, multicentric, active control parallel group study. And at month 3, if you see out there, there was a reduction of 37.6% of mean IOP with this suspension of brimonidine and brinzolamide. So the fixed dose combinations actually did well, and if you have a look there, you have first on your extreme left timolol, the pointer is not working, on your extreme left you have timolol, then you have the fixed dose combination, and then you have the fixed dose combination compared with timolol. So if you look at the nocturnal intraocular pressure and the p value there, so the red box that you see out there actually shows you that the fixed dose combination actually had a much better effect, more significant than as compared to timolol. So when to consider surgery? Surgery is generally considered when all medical treatment fails, and if you look at that graph out there, it has been also published in this study that trabeculectomy does provide a statistically lower mean IOP and the range of IOP for 24-hour control in a day when the maximum medical therapy fails. So in summary, basically intraocular pressure tends to fluctuate throughout the day and over longer periods. Larger long-term IOP fluctuations are associated with progressive increase in the visual field deterioration. Therapies increasing outflow appear to be better for stabilizing intraocular pressure than those reducing aqueous production. So there you have uveoscleral agents like prostaglandin doing better than timolol, which reduces aqueous production. Greater attention is needed to understand the efficacy of glaucoma therapy for providing diurnal intraocular pressure control. Prostaglandins have shown proven effectiveness in diurnal IOP control, and when prostaglandin analogs are contraindicated, fixed dose combinations like brinzolamide brimonidine can help achieve the diurnal IOP control. Thank you for your attention. If there's anything you want to ask, you're free to ask. Yeah, it's actually difficult. Yes, so basically number one is it's difficult to do diurnal variation because most of us being in private practice don't have a resident or someone who can do it throughout the night, and also it does cause the patient difficulties in waking up at night. So what we do is basically we call it the random IOP or the office IOP, where we measure the intraocular pressure. Say in the morning we start at 8 o'clock and every 2 hours we measure it up to 6 o'clock. So that would give you actually a fair idea of what the intraocular pressure is. And of course the main indications of measuring intraocular pressure is NTG, normotensive glaucoma, where you must actually do a diurnal variation. Could you use a microphone, please? Is there a microphone?
The diurnal variation of the IOP, but on the high normal border. When I found that my patient's IOP at the day, for example, 20, and the night is 22 or 23, is acceptable or could be considered as a margin patient glaucoma suspect. The diurnal variation is not more than the accepted range, just 2 or 3.
So if you go by literature, literature says that if the variation is 4
Yeah,
4 millimeters of mercury or more, that's when it is actually.
but it's
yeah.
but it towards the high border, the high normal border is 22 and 90.
Yeah, so you
it
could
doesn't
observe
exceed.
the patient actually, because even in a normal healthy individual, the pressure at night is higher than the pressure during the day. Or in the supine position, the intraocular pressure is higher than when you're sitting at the slit lamp.
Yeah, okay.
So you
but
could actually observe the patient maybe over a period of time and then decide on treatment.
But if
provided-
I missed that, despite all the other features are within normal,
Yeah.
if I missed that, could I prescribe a working as a timolol?
Timolol actually does not work very well at night because it's a beta blocker. So we generally advise, if you are giving your patient timolol, to give it before sunset, the 12-hour interval. So if you want to control the nighttime intraocular pressure, the best thing is the prostaglandin analog, provided of course the gonioscopy shows that angles are open.
Even in this figure?
Yeah.
Okay, thank
Yeah.
you very much.
Thank you.
So good afternoon, and that was an interesting prelude by Dr. Chandrima about the treatment of glaucoma and diurnal curves, and I would like to take you on another track to talk about the maximal medical therapy in the Indian setup. As we know that we are aiming to treat the glaucoma. The European guidelines say to maintain the visual function with a related quality of life and cost. And the American Academy says to stabilize the optic nerve and the RNFL status and to maintain a stable visual field. So that is our aim in treating glaucoma. As we know, the intraocular pressure is the only modifiable risk factor, and it has to be managed by medical, laser and surgery therapy. The goals of therapy that we do is achieve a target pressure, reduce the IOP fluctuations, as Dr. Chandrima said, administer glaucoma medications which have the least side effects and affect least to the quality of life of the patient. Achieve the treatment that is affordable and sustainable in cost for the patient, monitor the structure function of the optic nerve, treat the non-IOP dependent risk factors such as low diastolic perfusion, diabetes, lipid and vasospasm, which may additionally contribute. And very, very important is educate the patients and his family as far as the method we are going to treat the glaucoma, and that it is a lifetime treatment and what they can expect as time goes by. As we know, we fix the target pressure. Dr. Chandrima has already shown us how we are going to do that. We are going to consider the glaucoma damage, the life expectancy, untreated pressure and additional risk factors, and last, if you know, the rate of progression. And as we know, we are going to set the target pressure based on all these factors, but all show that lowering intraocular pressure is the key. And we have various drugs classes which are available to us in India today, that is prostaglandins, beta blockers, alpha agonists, carbonic anhydrase inhibitors and cholinergic drugs which is available to us. There are some new class of drugs which are coming up now but not yet come into India. If you consider the efficacy of each of these, the prostaglandins are by far the most effective, which reduce intraocular pressure by 30 to 35% from baseline. The beta blockers and the alpha agonists are somewhat comparable, coming in the 20 to 25 range. The carbonic anhydrase is the weakest, comes into 15 to 20%. The cholinergic agonists, that's the pilocarpine, they can increase by 20 to 25, but I would add that would also depend on the structure of the angle, and patients who have some amount of angle closure seem to respond better. Time out already? He says time is out. I don't think 15 minutes are out. I think it is the timeout of the previous session. So you please just adjust the timing correctly, because there this guy puts up a board saying time is out. As Chandrima pointed out this algorithm already, I am going to skip that. But very important is that what is the point of treatment when you are going to give so many medications? Are the patients putting the drops correctly? And you can see that when you have more than 2 IOP lowering agents, how many patients are actually putting on monotherapy. Even in simple ocular hypertension, where there are no glaucoma changes, only pressure is high, 40% of patients need additional drops in the first 5 years. So the amount of drops we need to use for the patients who have moderate glaucoma and severe glaucoma, you can imagine that a lot of percentage, going up to 75%, require more than one group of drugs to be used to control their glaucoma effectively. And we have to consider how do we add a second drug. So if the monotherapy is not enough, then we are going to think of adding, but we must consider the drug which is having an additionally different mechanism or a complementary mechanism of action before as to choose as the second drug. So if you have used an outflow drug as your first drug, then use an inflow drug as the second additive, and recommend that the treatment complexity, adherence and washout effect are taken care of. And now we are very, very conscious about exposure to preservatives. When we increase the number of drops, if all the medications have the same preservative, then amount of preservative going in the eye seems to be going up many-fold, and that is very important because it has detrimental effect in the long run. The drug absorption, if you put the second drop very close to the first drop, it has a kind of washout effect, and that reduces the efficacy of the first medication. So there has to be a good interval between 2 successive drops. Non-adherence is definitely a big problem, and if we are using 2 separate bottles, more number of drops, and we have good studies to show more the number of drops, the bigger the problem of compliance and adherence, and therefore fixed drug combinations seem to make a good sense. Dr. Chandrima mentioned this in her talk, and these adherence rates eventually impact the stability of the fields. So non-adherence leads to poor compliance, leads to progression more rapidly than if we are getting better adherence. So fixed drug combination definitely reduces the complexity of the treatment and gives you potential benefit of additive efficacy, preservative exposure reduction, tolerability being better, dosing frequency being more comfortable, so you get better adherence. Because of the inherent advantages, you have fewer drops and you have a single bottle with multiple drops. This is definitely the way to go when you know that you need more than one drug. But most important thing, as Chandrima pointed out, when you are going in for treatment with more than one drug, you should be particular that each additive medication you are adding to the regime should have a therapeutic benefit, and you have to see that before you start a fixed drug combination. The guidelines, whether it's the European Glaucoma Society or the American Academy, say that there is rationale in the studies to support the decrease in the number of applications per day and thereby increase the compliance, and they support the use of fixed drug combinations. Today in the market you get fixed drug combinations, all of which were mentioned by Dr. Chandrima. They contain the beta blockers except the beta blocker carbonic anhydrase combination, that is brinzolamide with brimonidine. All the other 3 have beta blockers in them. So with each of these drugs you are getting additive effect and they are increasing your efficacy. So how far are you going to go? What is the maximum number of drops you are going to give a patient? That is what constitutes maximum medical therapy, or MMT as it is called. It is defined as the achievement of the greatest possible IOP reduction with the largest number of medications that a patient can tolerate and is willing to be compliant to administer regularly. So different factors vary from patient to patient. You cannot have the same formulation for everybody, which constitutes MMT. A simple regime could be not interfering, minimum interfering to the patient's quality of life. And as I said, you have to make sure before you start maximal medical therapy approach, you have to be sure that each of these drugs is working for that patient. Second is that he or she is going to be able to maintain that same dosing schedule for a long period of time without complications and without getting affected in the quality of life too much and financially. These 3 factors you have to keep in mind. So the PG analogs, beta blockers, alpha agonists, and carbonic anhydrase inhibitors, when used all together, they are additive to each other. We know that from many, many studies. But as I explained earlier, you have problems of dosage and schedule, preservative exposure, ocular surface, and cost. And that is reduced by fixed drug combinations. So when you have a maximal medical therapy scenario where you are going to use, you definitely need to use fixed drug combinations in your formulation. The physician, before starting maximum therapy, is going to consider the side effect profile. So you have to be sure that each component side effects are not occurring in that patient, and try to organize in such a way that you just have drops morning and evening, because afternoon or midday drop installations definitely are proven by many studies to have poor compliance. And if you are not able to get a proper regime for this, opt for a laser or incisional surgery, and the approach has to be individualized for each patient. So you have an option one where you have the combination of a beta blocker and a topical carbonic anhydrase inhibitor with a topical prostaglandin analog or brimonidine. So that is one combination of a maximal medical therapy. Or you can have a PG analog with a BID fixed dose combination of timolol and a BID fixed drug combination without timolol. So you can use these. The last, and which we are now talking about, is the PG analog beta blocker combination with a brimonidine and alpha agonist and carbonic anhydrase inhibitor, that is brinzolamide combination. So you have 2 bottles, each having 2 drugs. So you are getting 4 drugs in 2 bottles, and it totally comes to 3 drops in a day. And there are many studies which have shown that these combinations are effective, and in the interest of time, I am going to just rush through them. The most important thing is that these quadruple combinations, where you are putting 4 drugs, have many possibilities. You have 4 molecules in 3 bottles, or sometimes 4 molecules in 2 bottles, and they are easier to administer, and there are studies to show that this is definitely working in a small percentage of patients, and that is definitely an option which you can think of in your daily practice with complicated glaucoma patients who need more medications. In summary, glaucoma is a multifactorial optic neuropathy, leading causes of blindness in the world. The primary factor, which is intraocular pressure, elevated intraocular pressure, can damage the optic nerve head, and this is the only treatable factor. Clinical trials have demonstrated the benefits of IOP reduction in reducing risk progression in established POAG. And in the last decade, there is a paradigm shift, and now we are increasingly using PG analogs instead of beta blockers as your first line. And substantial portion of patients require more than one drug. Up to 75% of patients are going to need more than one drug for adequate control, and that's the time when fixed drug combinations come into place by improving the dosage schedule, reducing the exposure, taking care of the washout effect, getting better outcomes. There are situations where you require more than 3 drugs to manage the glaucoma, and you have to consider the maximal medical therapy scenario and get the maximum possible IOP reduction with the maximum number of drops that you can tolerate and afford and administer regularly. The true MMT uses one choice of each available class of anti-glaucoma medications. Different factors vary from patient to patient to determine what is MMT for that particular patient. Because prostaglandin analogs, beta blockers, alpha agonists, topical CIAs are additive, they can be used in conjunction and interchangeably. Treatment has to be tailored to the individual patient before going further. Thank you. If you have any questions.
Yes, sir.
Yes.
When you find a patient with already prescribed anti-glaucoma and they are not sure that he is not glaucomatous or not, there is no findings, just anti-glaucoma drugs, and the IOP is okay, within the normal range. How many days you will stop the anti-glaucoma treatment to be sure that this patient needs anti-glaucoma or not, as an ocular hypertension?
So you want to stop the drug, whichever is being put, and recheck the patient after how many days? That's the question.
Yes.
So that varies, it differs from the different class of drugs. For beta blockers, the washout period minimum has to be 3 weeks.
3 weeks.
For prostaglandins, it is 1 month.
1 month.
For alpha agonists, it is about 15 days, and for carbonic anhydrase inhibitors, even 3 days is enough because they are very short acting.
Okay, just 1 week is not accurate.
No, they don't
Okay.
act. So if you just have if it's not showing much of changes on the optic nerve and the visual field, and you have stopped all the drugs, if you call back after a month, all of them are washed out.
Yeah, okay. Thank you.
Thank you.